Thank you, Enzo and Francesco, dear friends. Good morning. I'm truly honored and humbled to participate again in this precious and peculiar mixtures of art, culture, science, and friendship. And I guess that we are indebted to the Gonzaga family for being here today. That's why I want to specifically thank the real Duke of Mantua, who's over there. Thank you.
I need that slide for the next 100 presentations.
Of course. Right. So thank you, actually. So keep taking your aspirin. Stay alive. We want this event to be durable. Now, speaking about durability, progressive beta cell failure is the principal factor responsible for the development and progression of hyperglycemia in type 2 diabetes. Now, with the exception of what we have just now heard from Roy, no pharmacological intervention has so far clearly demonstrated to be able to reverse and or to halt progressive beta cell failure in type 2 diabetes. Now, how do we define disease progression? Well, one way is to define is that increase in drug dosage, frequency, of number of lowering glucose drugs needed to maintain appreciable hemoglobin A1C control. The other way to define is like more than half percentage point raise in hemoglobin A1C unexplained by acute modifiable factors while using the same drug regimen in the absence of an intercurrent illness and inflammation or so on. Or we can take a more clinical approach to the definition of progression and define it as the occurrence or worsening of type 2 diabetes complications in spite of standard care over a pre-specified time period. Now, in this context, how do we define drugs' durability? And the durability of a drug or of a combination of drug may be defined as the ability to postpone or delay disease progression in a safe and well-tolerated manner. This would be a very ambitious way to define durability. In a more practical clinical way, we may define durability as the capacity of a drug or a combination of drug to maintain hemoglobin A1C control over an extended period of time. Here comes the first problem. What do we define as an appreciable amount of time? 12 months, of course, the minimum time, but we would like to have like 5, 10, 15, or 20, and so on. But then why should we seek durability in a drug for diabetes? Well, there are several good reasons. One is that to delay the need of additional drugs means that we delay the need to make the treatment more complex. A complex treatment exposes to more costs, exposes to more possibility of adverse events, or decreased adherence. Besides, we want to delay or avoid the need for insulin therapy. Of course, insulin therapy is not a master. I still believe that since beta cell is failing, the therapy for type 2 diabetes should be insulin, but we all know the problem with insulin therapy, the cost, and the risk of weight gain and hypoglycemia. So we can stay away from it, fine. Then if a drug proves durability, this might mirror an effect on slowing disease progression. We'd like to have the drug to cure diabetes and not to treat glycemia. Now, if I stay on a drug and this keeps my hemoglobin A1C at the good level, this might mean that I'm actually using a disease modifier in some way of altering the progression of the disease. As we will see in a few minutes, unfortunately, there's no clear data showing that any drug is, at the moment, able to do this. Then how do we look for diabetes drug durability? And this is where the dualism between science and clinical practice comes into place. We can look at the durability in prospective randomized controlled trials. We would agree in defining this science. Then we can look at observational registry study, mostly retrospective, what are called real-world trial or clinical practice. I'm not really like the real-world thing because real patient in flesh and bone, actually more flesh than bones usually being type 2 diabetes, are the one you enroll in the RCTs. These are mostly registry data, so I would say silicon-world evidence, which is proxy of real-world evidence. And we'll say something data about this. But even with the prospective trial in looking at durability, we do have a lot of problems. The first is the one we mentioned before, trial duration. How long should a trial go for a drug to be defined durable? Second, how do we define durability? We'll see in a moment the example of the ADOPT study, where durability was defined as the ability of having fasting plasma glucose below 180 milligrams per deciliter. That's hardly a durability test. Then who do we study? Well, naive to treatment, already metformin, how long the duration, and so on. And finally, comparators. We do not have, unfortunately, a gold standard for durability. Nothing is durable forever. So basically, we have to decide whether the Duke of Mantua was right in singing questa o quella per me pari sono, which means I don't care if I take this woman or the other, I want them all, which is the wishful thinking. But we need to compare one drug to the other to see which one might be the best. So actually the paradigm, I believe, of the durability study, comparing different drugs, is the ADOPT study. I was very discomforted preparing this talk and looking at this, the date of this publication. It's 2002. It's about 20 years ago. To me, it looks like yesterday we were in Cape Town looking at the presentation of the data, which means that I'm old, very old, if 20 years passed so fast by. Now, in the ADOPT study, they were looking at the possibility that the rosiglitazone therapy was able to ensure a better control in terms of durability as compared to metformin and sulfonylurea. The background idea was that TZDs could be taken as disease modifier, and that the action of the rosiglitazone on metabolism could be such as to prevent progression of the disease. Now, you all know the result of the trial. Again, I point out that it was not very much ambitious in terms of definition of durability. They were looking at people staying at a level of glucose in the morning below 180. But still, if you compare what happens with sulfonylurea, with metformin, and with TZDs, what was observed is that even though for along the 5 years, for all treatment, you could see actually a trend toward relapse versus a better control, a not so good control, I should say. In the sulfonylurea, were the first one to exert an efficacious dropping of the glucose, but then it would go back. Metformin was in the middle, and the rosiglitazone was actually the best. And the conclusion of the trial was that among the 3 drugs tested in monotherapy in subjects naive to treatment, rosiglitazone was the most durable. Second place was for metformin, and sulfonylurea were the less durable. This data, in the durability of metformin is better than SU, is actually confirmed in a so-called real-world data. These are the data for the Swedish National Diabetes Register. As you would notice, I put in all of this slide, because now it gets boring, because we are going from trial to trial. And on the start, you have the duration of the observational period in RCT or in the retrospective. And if you see this sign, reality check ahead, these are registry data. Okay, so this is the Swedish register, and they were looking at subjects started on monotherapy with sulfonylurea and metformin, and the definition of loss of durability was either all failure or add-on of the second drug, or switch from one drug to another. And over all of these 3 endpoints, the registry was demonstrating that metformin was more durable than sulfonylureas, confirming in a way what had been seen in the ADOPT trial. The conclusion actually by Ekstrom was SU and methylglycinide were associated with a 2.5 to 3-fold increased risk of add-on treatment of a second agent and a 4-fold increased risk to switch to a new agent as compared with metformin. Although, during the 6 years, even subjects with metformin experienced a 30% rate of shifting to another agent. So, metformin, superior durability. Okay? Now, these were subjects started in monotherapy with sulfo or metformin. You are all very familiar with this. And no matter the controversy with the latest ESC guidelines, we still believe the metformin is the stepping stone for glucose therapy, on the top of which we add several other drugs. So now we are also concerned on the fact that whatever we add on the top of metformin has sufficient durability. And you know very well what choice we have. So let's say at the few data which I've been able to find and put together with comparison of this different option on the top of metformin. Now this is a meta-analysis of a head-to-head trial comparing safety and efficacy of gliptins versus sulfonylureas. It is only the limitation of meta-analysis, but still, if you look at the coefficient of durability, it looks like on the top of metformin, in this RCT contest, the gliptin were favored versus the SU in terms of people to be able to stay on the drug for a longer time before any addition or any switch. Now, countering this are data from a UK registry from general practitioner, again, reality check ad, where they looked over the period of 5 years observation at subjects who were started after metformin with the addition of sulfonylurea or the PPAR inhibitors or TZDs. Of course, the number of the subjects in each group is widely different. There's no mention of a precise propensity score matching in the course of the paper, but with this crude analysis, they come out saying that the best combination in terms of durability was TZD on top of metformin. Second in place came metformin plus SU, and then before analysis. The conclusion were then in routine clinical practice, as could be seen in this registry from UK general practitioner, adding a gliptin to metformin was associated with an increased earlier requirements for treatment intensification compared to adding an SU or TZD. And again, addition of TZD to MET resulted to be the most durable treatment of the three explored. Plenty of bias in the study, but still, I mean, there's a sort of conflict between what comes out from the meta-analysis of the RCT and what comes out by single report on an observational trial. Of course, instead of a gliptin, you can add a gliflozin to metformin, and there are several studies which have compared the efficacy and safety of sulfonylurea versus gliflozin in type 2 diabetes. This is one of the longest, and the first author is sitting in the audience. And if you look at the change in hemoglobin A1C from baseline, you do see again that at the end of the 4 years observation period, the control was better in the group treated with dapagliflozin versus the group treated with glipizide. What is, again, disappointing is that the lowering of hemoglobin A1C from baseline in the best group was minus 0.1 at the end of 4 years. Again, giving us the sad indication that we do not have yet the durable treatment which halt disease progression, but still, this was better than glipizide. Very similar data in the comparison of empagliflozin with glimepiride Again, the same trend toward the relapse after over 2 years of observation. And again, at 4 years, you have a significant difference between the sulfo and the gliflozin, and again, with a coefficient of durability, which was better for the empagliflozin than for the glimepiride. In this particular study, only 23% of patients in the empagliflozin group received rescue therapy over the observation period, while more than a third of patients had to receive rescue therapy in the glimepiride group, which still means that a good fourth of the patients could not be managed by gliflozin plus metformin alone. But then, since the game is becoming more complicated because you have several options to put together after metformin, you may also want, the same data are look the same for canagliflozin, but the data on canagliflozin we have available, at least I was able to find, were at 2 years and not at 4. But again, the same trend of final hemoglobin A1C being slightly better with the gliflozin than with the sulfonylurea. Now, of course, having, as I said, different options, you don't want to compare only sulfo versus glifo or sulfo versus gliptins, but also, why not, gliptin versus gliflozin. And this happens in this review by Cliff Bailey, who put together post-hoc analysis from phase 3 randomized controlled trial of dapagliflozin versus saxagliptin. So it's for sort of in-house comparison. And again, showed that the coefficient of durability was better for the gliflozin than for the gliptin. This data actually are supported also by reality check, an observational study. This was, I think it was the Canadian registry, and they were looking at subjects started on canagliflozin versus subjects started on sitagliptin. Then they matched the group, they applied propensity score, they look at the duration of time before a switch or an adding on the therapy, and they looked at under the different definition of the endpoint. Failure to maintain hemoglobin A1C below threshold. Sita failed more than canagliflozin. Failure to maintain hemoglobin A1C under threshold or prescription of a new oral antihyperglycemic agent, Sita performed worse than canagliflozin. So, in a way, Cana patients were more likely to remain below hemoglobin A1C thresholds during the long-term follow-up than did patients initiated on sitagliptin, both on the top of metformin. And this, for once, is in keeping with what was the result of the analysis of the RCT performed by Cliff Bailey. Now, we have talked so far about oral agents. What happened with injectable? So let's go back and look at monotherapy with injectable. And again, there's a trial with liraglutide, 2 years of duration. This is the profile of hemoglobin A1C. And the comparator was glimepiride. Also in this case, after 2 years of observation, the hemoglobin A1C at the end of the trial was better with the GLP-1 receptor agonist than with the sulfonylurea. And if you look at the percent of participants which stayed below a certain threshold of hemoglobin A1C, this again was larger for the liraglutide treated patient than for the sulfonylurea treated patients. If we now move from monotherapy with injectable to add-on to metformin, again, in the comparison with sitagliptin in this case, liraglutide performed better, but this was both in terms of achieving a more important target hemoglobin A1C and staying on the target after a 2 years follow-up. Even in this case, you see a slight slope of the curve trying to go back versus a worse control. This slope is actually a little bit worse with sitagliptin. Now, we also have a 6-year trial with exenatide once a week. This has been once defined by Gene Salt's statistical requirement because it was a study with open label for a long period of time and with a progressive vet in terms of loss to follow-up of people being in the trial. So the number were becoming smaller and smaller as you go on in the follow-up. And again, if we look at the time to the addition of lower medication in years, again, this is still the picture of an agent which is not able for a long time to be enough by itself to keep patients in good control. And again, you see that from year 1 to year 6, you see a small increase in hemoglobin A1c. And these are the survivors, because in that analysis, you don't put together also the subject who actually were lost to follow-up and probably did go to additional treatment. Now, this is sort of discomforting because we had put a lot of faith in treating with the GLP-1 receptor agonists as a way to prevent beta cell progressive failure. In the incretin-based therapy, there was the promise of being able to change the history of the disease. So far, the promise has not been kept. I think there is still hope. But when Bank et al. Looked at the beta cell function after treating with 3 years with exenatide compared to glargine, and these were the tests done to look at beta cell function. Once you do the test after 1 year, and this is exenatide, this is glargine, you see an important difference. But these were still on treatment. If you redo the test 4 weeks after treatment, again, the lines are superimposable, which we do have an acute effect, but this doesn't stay there. So you need to have the drug there in order to awaken the beta cell and keep it awake. A little bit of hope could be seen in this other data generated by the same study, where if you look at the beta cell disposition index, which is one of the several proxies that you might have for beta cell function, off drug, after 3 years of treatment, you could see a slight difference in the disposition index, and this being still positive in the exenatide-treated patient while going down in the glargine-treated patient. And this is like the glimpse of hope we have at the end of the tunnel. We did have some data on people naive to treatment. These were early diabetics or subjects with IGT who were treated with either liraglutide or lifestyle intervention to the same amount of weight loss, which was not, unfortunately, the much larger weight loss that Roy showed us. They were looked at before and after losing 7% of their initial body weight. And usually, as an average, they stayed in treatment, either lifestyle alone or liraglutide, for about between 8 and 12 months. And thanks also to Riccardo Bonadonna, who performed the analysis, the calculation and the analysis, we looked at the beta cell function in that although subject had lost the same amount of body weight, although actually we were able to demonstrate a slight greater loss of visceral fat in the liraglutide subjects as compared to the lifestyle, we did see actually a small but significant better improvement in beta cell function in the one treated with liraglutide. Again, glimpse of light at the end of the tunnel. Now, in the last 4.5 minutes, we have talked, looking now at data with monotherapy or addition of a drug to metformin. What happened if we start with more than one drug? And again, it was just released the Verify studies where 2 different approaches was compared, metformin plus vidagliptin from the start, or metformin plus placebo, and then eventually going on to different therapy. What does the study tell us? That if you look at the group with the combination from the start, you see a significant reduction in relative risk for time to initial treatment failure. is observed in the early combination group, and the relative risk for time to second treatment failure during period 2 was also significantly reduced in the one who started with the combination. So the conclusion was that the strategy of an early combination treatment approach with vildagliptin plus metformin in this particular study in patients with newly diagnosed type 2 diabetes significantly and consistently improves long-term glycemic durability compared with metformin monotherapy. And the study results indicate the long-term clinical benefit can be achieved more frequently and without tolerability issues with early combination treatment compared with standard care metformin treatment. Now, why be limited and why start with 2 drugs? We can start with 3 drugs. And that's what Ralph Resonto has done in the EDICT trial, small study, single-center study, where subjects were randomized in triple therapy, metformin plus prior plus exenatide, or conventional therapy, stepwise metformin, limepiride, and androgen. And this is the allocation of patient, not like enormous number at the end of the day, but the demonstration that if you start with triple, after 6 months, hemoglobin A1C gradually increased with conventional therapy, while remained stable at 5.95 with triple therapy. An extension of the study was presented last year at the ADA and showed that after 72 months of treatment, the subjects receiving triple therapy, 6 years duration, experienced a significantly greater reduction in hemoglobin A1C after a mean follow-up of 6 years. I guess that nobody was surprised by this. If you start shooting at different targets and multiple targets, you probably have a better chance of hitting more of the mechanism causing the progression of the disease. This is not proof that the disease was halted, at least adds additional hope. We might have, and the study conclusion was that combination therapy with metformin, pyroxenatide in newly diagnosed type 2 diabetes patients produced a greater and more reduction in A1C than sequential add-on therapy with metformin, sulfo, and basal insulin. Some additional answers we might have from the GRADE trial. However, the GRADE is a study which was held in the crib because not even egliflozin in the suggested follow-up. And I wonder whether we're going to have a large enough number of subjects to be able to conclusively decide what is the better path to take after metformin in subjects with type 2 diabetes. Now, durability in glucose control in type 2 diabetes. Back to the first slide. We enjoyed the other night the vision of the thyroid gigante. With data between 1532 and 1535, this is 500 years. This is durable. Unfortunately, we do not have anything as durable as this in treatment for diabetes so far. So what can we humbly conclude? First, the no-intervention, in my opinion, has so far conclusively demonstrated to be able to halt TDM progression. We'll have to look at metabolic surgery, but still it's too early to be able to conclude anything. Metformin, this is an innovative drug, gliptins, gliflozin, and GLP-1 arrays appear to be more durable than sulfonylureas. And this is hardly a new information that I'm giving you. Early combination therapy, double or even triple, might provide advantages over stepwise add-on therapy in obtaining and maintaining good metabolic control. I guess we have to look carefully at this data, maybe produce some additional data, and on the basis of this, being able to more closely shape our guidelines for treatment. But anyway, use of safe identification treatment should be implemented since diagnosis to avoid unnecessary glycemic burden. We go back to glycemic burden, which I think is still important. Andrew was agreeing with me, treat to benefit, but you need to treat to target in order to treat to benefit and minimize the risk of complication. Thank you very much.
Thank you, Agostino. Very comprehensive presentation, nice data to discuss. Leif.
Yeah, thanks, Agostino. Very nice presentation. But you seem to consider durability is lowering of hemoglobin A1C. Is that not a too narrow target when it comes to treatment of type 2 diabetes? Because it's not all about lowering hemoglobin A1C or glycemia.
This is exactly what I said in the second slide, which we should probably take a more clinical approach to durability. But I don't believe that there's enough data over there which will allow us to look at clinical durability in terms of prevention of complication, comparing among each other different drugs. And that's why I am skeptical on the fact that we are going to be able to provide a final and definite algorithm which should be the best for treating diabetes. Having said that, I do believe that whatever has been accumulating now in terms of data on cardiovascular renal protection needs to be taken into consideration, and at least in the ESC guideline for an example of this. But I would be worried of ever emphasizing trials where the population which was studied is largely different from what we see every day in our clinic, and where actually the amount of benefit, if we exclude the astonishing decrease of death in the EMPEROR study, the amount of benefit is all in all small. Of course, we welcome that with the great inspiration, because for the first time we were seeing something good happening in the territory of heart complications in diabetes. But still, if you look critically and skeptically at the data, the overall largeness of the effect is still small.
And all these studies in type 2 diabetes, they have been considered type 2 diabetes as one disease, which it's not. And you also showed data from the ADOPT study, where actually, if you did then the clustering, as also Andrew Hattersley's group did, the rosiglitazone effect was only seen in the insulin-resistant subgroup. The sulfonylurea in the age-related, whereas metformin was seen in all. So I really think in the future we have to start to look into heterogeneity of diabetes more.
I totally agree with you.
Questions? Agostino, you totally skipped Tosca, which Tosca study, it was created for by the Italian Diabetes Society. There was a long follow-up of people, a huge number of people treated with pioglitazone as compared to SU, and time to insulin rescue therapy, which was the only possibility to try to get back to the target, was clearly different in that study. So durability was demonstrated even in a larger study. And speaking about PIO and its demonstrated durability, we have the possibility right now to make combined treatment with 4 drugs and 2 pills if we want, because we have evidence that for some drugs, even half the dosage is sufficiently effective, efficacious in reducing A1C. So you can make a sort of empirical combination if we wish, with 4 drugs and 2 pills. Do you agree?
You're right. I agree. Given the fortunate availability of different principles which actually hit on different targets and on different mechanisms of action, we might become sort of sorcerer and try combinations in different ways. I would advise against being sorcerer and trying the own recipe, and again look at data which have solidly demonstrated benefit of the different combinations. And you said that Once you start adding drugs, you have, of course, also a problem of adherence. Under this respect, I welcome very much fixed combination of drugs, which may allow to reduce the burden of the pills or injection intake. You know that reimbursability of fixed combination of gliflozin plus gliptin has been approved last week in Italy. You know that in the States, I guess, already available triple combination of gliptin, gliflozin, and metformin, which can even more reduce the number of pills. If you combine this with weekly injectable analog, this again would play into the possibility of the patients to adhere to complex regimen in an easier way. And I guess this is the way we have to move to, trying always, even if Andrea doesn't agree with that, to put together cost and benefit, final benefit.
Stefano?
Just a point. You really look into the different possibilities in terms of gaining, in terms of durability. However, the durability has to be considered as a balance between the efficacy and the tolerability. So when you, for instance, discuss about pioglitazone and so on and so forth, there is different degree of tolerability most likely as compared to other. And this also brings in the same question when you start using more than one drug. So what we did, and actually what was very comforting to us in Verify, is that overall, as expected, because the two drugs that we are using are very well known for their tolerability, that there was no increase in the potential signal in terms of tolerability. So I think that really you needed to factor in also the tolerability in terms to ensure adherence to some extent and the potential for continuing using the drug.
True, but this is a way taken care of in the observational study. Because once you look at registry and there's a switch or an abandoning of a drug, this, of course, takes into consideration also patients who abandon the regimen because they were not adherent anymore. And usually, as you know very well, the registry are looking at prescriptions. So if you are not adherent, I don't think you take the trouble of going to the pharmacist and getting the drug. So there are several biases and difficulties interpreting the observational study, but this is one field when they will come handy because we'll take into consideration also people abandoning the case of they cannot tolerate the drug anymore.